This is Think Out Loud on OPB. I'm Dave Miller. The University of Washington School of Medicine does not just take place in Washington. Since 1971, it's also had a program that serves students in and from Wyoming, Alaska, Montana, and Idaho. It's called the WWAMI program, and it's intended to bolster the rural physician workforce in those states. A recent $25 million donation will help to bolster this program and fund students who want to practice family medicine in rural and indigenous communities. Tim Dellit is an infectious disease doctor, the CEO of UW Medicine, and the dean of the medical school. Kenya Morales is a second-year medical student who's currently taking part in the WWAMI program and is in the TRUST program that stands for Targeted Rural and Underserved track at the University of Washington School of Medicine. They both join us now. It's great to have both of you on Think Out Loud.
Well, thank you for having us.
Dr. Dellit first. So I mentioned this WWAMI program stands for Washington, Wyoming, Alaska, Montana, Idaho. How does it work?
Well, WWAMI was created over 50 years ago in the early 1970s. And the idea was, how could we collectively increase the number of physicians going into primary care, increase access to care, and the number of physicians serving our rural communities across the vast northwest of the U.S. and Alaska, covering 27% of the landmass. And the concept that if we did this as a community-based education, building those relationships with the students and the communities that they serve, that they would be more likely to return and serve those communities after they trained. And so that was really the crux of the creation of the WWAMI program over 50 years ago. And unfortunately, many of those same needs are still present today in terms of the lack of access to healthcare in many of our rural communities across the Pacific Northwest and Alaska.
Oh, I was going to ask you that. So this was identified in 1971 because of the acknowledgement of a shortage of rural doctors. And you're saying that it hasn't really gotten better in the intervening time?
I would say that we have made progress in the sense that if you look at our history, over 65% of our students return and practice within the WWAMI region. And yet, despite those efforts, we still have a paucity of physicians. If you look across our states, we have the lowest number of physicians per capita of any part of the U.S. And I would say if you look at the impact of the pandemic, and when we saw loss of individuals in healthcare, and then now, particularly as we face some of the impacts of H.R. 1 and the Medicaid impacts for our rural communities, this continues to be a significant concern in terms of how do we increase access to care for our rural communities and particularly in the Northwest, our indigenous communities.
Why was this seen in 1971 or even why today, to zoom forward to the institutions that you lead? Why is this seen as the responsibility of the University of Washington? I can imagine UW saying, we've got our hands full in the Seattle area, or let's even say for the state as a whole, as a statewide institution, but we don't have the resources to also worry about Wyoming and Montana and Idaho and Alaska.
Well, this was really developed as a partnership. And so WWAMI is founded on partnerships. And how can we deliver cost-effective medical education? Back in the 1970s, it was recognized it was cost prohibitive for many of these states to have their own medical school. There simply wasn't enough population or resources to be able to support that. And so it was really a creative pilot, if you will, that began as an experiment and then has lasted over 50 years, but it's all based on partnerships. So the way this works is that our students spend the first 18 months, essentially their classroom time, with our partner institution. And then their third and fourth year, when they do their clinical training, they can rotate anywhere across the 5 states. So as an example, we have 30 students a year in Alaska. They start at the University of Alaska in Anchorage. We have 40 students at the University of Idaho, 30 at Montana State University, 20 at the University of Wyoming, 60 at Gonzaga University in Eastern Washington, and then 100 here in Seattle. So it's really all about partnerships and how can we collectively provide this education in a cost-effective way across this large rural region.
Kenya Morales is with us, as I mentioned, finishing. Am I right that you're finishing your second year right now?
Hi, thank you for having us. I am finishing my first year, so
Finish.
I
Oh,
am a
about
brand new second year
okay,
student. Yeah.
brand new second year. Okay. Did you always know that you wanted to be a doctor?
I knew at a very young age, after many times of interpreting for my parents who were only Spanish speaking at free clinics and seeing the need for Spanish speaking providers serving them and others in my community, in addition to seeing the need for physicians at these free clinics and at clinics that were able to see patients who were low income and uninsured. I was interpreting for them ever since I was a child into high school, and that kind of led me on my path
Huh.
where I am today.
So you were a kid helping
Mhm.
your parents and being an interpreter, going back and forth English and Spanish in free clinics, and there was a part of you that said, "I want to be on the other side. I want to be a doctor at clinics like this."
Exactly. And as I got older, I saw that this was a bigger problem, not just of the lack of Spanish speaking physicians, but the need for just physicians serving in Idaho and serving rural and underserved communities. So that's something I later discovered with my experiences.
What role have you seen that community health workers or rural physicians, what role do they play in communities?
Oh my gosh. Well, I was a community health worker for 2 years before starting med school. So I was, and I can speak so highly of the work that community health workers do, because as we know that the social determinants of health on a patient really impacts their ability to heal and to be able to afford the medications that the doctor needs them to take, right? So without resources, patients can't get better health. So community health workers are really a backbone into helping um, physicians and the clinic goal team help patients. And rural doctors who are aware of resources in their community also serve a big part because they're able to refer patients to services that they know are needed and would be helpful.
Dr. Dellit, how do you recruit students from rural parts of these 5 states? How do you find your students?
That is a great question. And it first starts with allowing these students actually see medicine as a possibility for them. That's why this gift is so critical because it decreases that financial barrier for them even considering the possibility of medicine. We have a number of programs around that ecosystem of how do we reach out to students in middle school, high school, undergraduate students, encourage them not just in medicine, but healthcare in general, and thinking about what those opportunities may be for them. So it starts at a very early age. And I think, again, there's an opportunity for us to do more here in terms of how do we engage the communities? How do we help support individuals from our rural communities really see medicine as an opportunity? What's wonderful about our students is they want to give back. They love these communities. They want to be able to give back to these communities, and we want to allow them a pathway to be able to do that.
Kenya, did you see, as we were talking about at the beginning, you saw the role that these clinics played for your own family, and you wanted to do that yourself. You wanted a career as a rural physician. Did you see a path as a kid or a teenager or even a young adult to make that happen?
The pathway was always set by my parents, who, even though we weren't financially well, always told me that we would figure it out. So I guess their confidence in me led me to say, I'll find ways or I'll find help. And the University of Washington is now that I'm in med school is and their scholarships are a big part of my ability to continue to, in this path and my ability to feel well of pursuing this path, when I was applying to med schools. But yeah, it's been through the help of scholarships that I was able to go to college and pursue now med school.
Kenya, what are the financial burdens of pursuing this path?
Well, it's definitely the over $100,000 in loan debt that you have after going through your medical school education. Um, and specifically wanting to pursue rural medicine, where you are a family medicine doctor in a rural community. You're not in a high paying specialty, right? Like in doing cardiology in a big city. So that's kind of a barrier some students face when wanting to pursue like rural medicine. Um, yeah.
So, and this gets us, Dr. Dellit, to the ways that this $25 million are actually going to be put to use. Can you give us a better understanding of the different buckets of money that you now will have access to going forward, and the idea of how they will make it easier for future students to pursue this career?
Well, I want to first start by thanking Bill and Carolyn Frankie for their vision and partnership in really supporting our students and lifting them up. So this is a $25 million gift. 20 million will be set up for endowed scholarships. So those scholarships will go directly to help support students who are interested in pursuing a career in rural medicine, serving our indigenous communities across the WWAMI region. Another 5 million will actually be used to help support some of that outreach, the recruitment. How do we identify and allow students to think about medicine as a possibility? How do we support students along their journey? Unfortunately, some of our students face housing insecurity, food insecurity, and so we often need to help support them and ensure that they are successful even after they get accepted into medical school, as well as academic support and other support that they need to be successful. So when we look at this, it's really transformational to be able to provide scholarships. And what we're anticipating is that ultimately this will support about 30 to 35 students a year for half of their tuition to decrease that financial burden that Kenya mentioned, which allows them to pursue their dreams and not their debt, especially going to serve rural communities, whether it's a family medicine physician or other physicians within our rural communities. And so for us, this is just transformational to support our students and ultimately to increase access to care for our rural communities.
Part of the national context for this is changes in federal loan limits for things like medical school. What does that mean in particular?
Yeah, I think that's a real significant barrier. When you look at the average debt for our students, once they complete, this includes undergrad, their medical school training, it's about $220,000 of debt. The new caps are going to be at 200,000. And so that is a real barrier for our students. We have got to lower that. And so this is a prime focus for our school. And this gift, again, $20 million going straight to support student scholarships, is an incredible gift, which we are so grateful for. And it's that financial burden that we've got to be able to decrease to allow students both to see themselves to come to medical school and then to be successful as they go on throughout their career. And again, to be able to serve these smaller communities.
If you're just tuning in, we're talking right now about a major new gift to the University of Washington's School of Medicine. It's intended to make it easier for future students who want to practice family medicine in rural and indigenous communities. Kenya Morales is already on her way. She is now in her second year as a medical student at UW. Tim Dellit is an infectious disease doctor and the dean of the UW School of Medicine. So we've been focusing a lot on the geographic piece of this, rural and indigenous communities. But I want to turn to the medical practice side of this, because we're really talking, if I understand correctly, about the practice of family medicine. So, Dean Dellit, first, why is family medicine such a focus of this program?
Well, so family medicine physicians, particularly in small rural communities, they do everything. They take care of individuals who may be pregnant. They help deliver the babies. They take care of the children, the adults. They help with end of life. They care for the full cycle of life. And we were talking a little bit about the importance of these physicians within their community. It's not just taking care of the individual patient, but they really are part of the fabric of that community and help the overall health of that community. And so family medicines are physicians are absolutely critical across our rural communities. I'll also just say that we need more specialists in our rural communities. It's just hard because of the number of patients who may need their care. And so we're constantly thinking about how do we extend our specialists out into our rural communities as well, or allow at least special tracks. For instance, we even have some of our surgical residents who go out and train in rural areas for that experience to understand what does it mean to be a rural surgeon, because it's very different when you are the only person there and the community relies on you to do everything related to their healthcare.
I want to hear more about the efforts to increase the availability of specialty care, but just to stick with the family medicine piece for a second, Kenya, how much are you attracted to this version of the practice of medicine as opposed to your desire to practice in a particular kind of place in a rural area?
Yeah, so family medicine is what is the specialty I'm interested in currently. I love that we're able to take care of the whole family unit and we're members of the community ourselves that really know how to best treat our patients. Um, and really, like, I would like to pursue a fellowship in OB and also be able to provide obstetric care in the community that I'm in and deliver babies and really be a present physician in my community and be able to practice just full spectrum rural medicine, which means do a little bit of everything and more.
Where have you been based for your first year of your medical education?
I am currently in Moscow, Idaho.
And as we heard from Tim Dellit, the first 2 years of medical education classically are more classroom based. Have you had any clinical pieces though so far?
Yes, definitely. The University of Washington School of Medicine is so great at getting their students into clinical practice early on, which I think is unique about our program, that we began school in July, and by September, October, we were already practicing clinical skills, and we were able to get into our critical access hospital nearby, or just the hospitals, to see patients in a group setting, and do some primary care clinical work with doctors in our communities.
2 years before the classic clinical rotations where you'll get a taste of all the different pieces of the potential future practice of medicine for yourself.
Yes, and as part of the trust program, I was able to begin my clinical experiences even before I started medical school as well. So they definitely um, take take us into the community right away, which is great.
Do you think that you've already been learning things that you could only learn in a rural setting?
Yeah, I believe so. From what I've seen, the physicians that I've worked with so far are so knowledgeable, are experts in many different areas that in urban settings, I've heard physicians say, go back to your family medicine doctor to learn more. But here, it seems like they have the answers and they're able to do procedures because they've gotten extra training because they know there's a need.
Tim Dellit, it seems like Kenya is in this for the long haul as a family medicine doctor, maybe with an OB addition in a rural setting. Is that a requirement? When students go through this program with the idea that they will become family practice physicians in rural or indigenous settings, do they have to? Could they then do, a cardiology rotation in their third or fourth year and say, you know what, I want to be a cardiologist in LA or Seattle?
Yeah, they're not absolutely required. We try to identify students who show a strong interest. And as Kenya did, students in our trust program, they apply for that program as they're applying for medical school. So that program selects out individuals who have said, you know what, I want to practice rural medicine. And if you look at the graduates of that program, a much higher proportion, but not 100%, end up practicing rural medicine. One of the beauties of medicine is that there are so many opportunities. And so if a student starts on that path and then later on they find they really love a different area, we want to support that as well. But I would say the vast majority of students who participate in the trust program will end up serving rural communities, but absolutely not a requirement.
I want to go back to the piece that we paused on before. Family medicine, these docs really seem like almost the decathletes of the medical profession, being able to do so many different things for so many different ages of patients. But as you noted, there is a really serious shortage of specialists in rural areas, and the economics make it really hard to change that. So what options do you see for more provision of specialty care in places where it's highly unlikely that specialists are going to move to?
Yeah, so a couple of ways we're approaching this, and we've to date focused our discussion on medical education within our medical students. But we also are trying to grow what we refer to as graduate medical education, meaning that once our students graduate from medical school, they go and do a residency program for an additional 3+ years, depending on what they go into. We need more residency programs across these 5 states. Because again, if you do your residency in one of these communities, you're more likely to stay there and practice after you complete your training. And so we're working with all 5 of our states to continue to grow that. One of the ways we do this, we have a family medicine residency network. We have over 30 residency programs that are members of that network. The network is coordinated through the University of Washington, and we do things like helping them set up a residency program. How do we do faculty development and continuing medical education? They have access to our library and other resources through the university. Another way we're trying to do this is really taking advantage of this amazing time that we're in when we see advances in AI, technology, engineering, and how that combines with medicine. How can we extend, for instance, telemedicine or digital health out into our rural communities? How can we leverage technology so that our patients don't always have to drive 6 to 8 hours to see a physician, but can we do things with remote monitoring or other technology to bring care closer to them? How can we leverage our specialists and connect them to the family medicine physicians practicing in these smaller communities for additional advice when needed? Right. And so we're always trying to think about, especially now, how can we leverage technology to extend specialty care? But fundamentally, the backbone of care in our rural communities, it's the family medicine physicians.
Tim Dellit and Kenya Morales, thanks very much.
Thank you. It's been a pleasure being with you.
Tim Dellit is an infectious disease specialist who is the CEO of UW Medicine and the dean of the UW School of Medicine. Kenya Morales is now in her 2nd year of medical school there. She is in the targeted, rural, and underserved track.